I want to talk today about isolated ostial LAD or ostial left circumflex stenting. This talk complements my prior 5 bifurcation talks, particularly ostial side branch stenting, which I suggest you review. There are two major stent strategies for isolated ostial LAD or ostial left circumflex. One is nail the ostium strategy or floating stent strategy, where you try to position the stent exactly at the very ostium without hanging much at all in the left main. The second strategy is what we call the crossover stenting into the left main, where you make your stent land very well into the left main, at least 6 to 8 millimeters in the left main, and you do pot in the left main. I will explain those in more detail. Always remember to double wire LAD and left circumflex, regardless of which one of those two techniques you use. And always try to IVUS the left main to ensure it is truly an isolated ostial LAD or circumflex disease, and ensure the left main is not moderately or severely diseased. And consider IVUS of the uninvolved branch vessel to ensure it is truly not severely diseased. For example, if you have severe ostial LAD, you may need to IVUS the left circumflex as well to make sure it's truly not severely diseased. I will describe the nail the ostium strategy, also called floating stent technique. So in true ostial LAD disease with normal left main and an LAD left circumflex angle that is very open, over 70 degrees and about 70 to 90 degrees, you may position the stent at the LAD ostium and make 1 or 2 struts, which is about 2 to 3 millimeter, hang across the left circumflex ostium, ideally a bit or halfway through the ostium of that circumflex, or occasionally 1-2 millimeter into the left main if that left circumflex caliber is small. So this is like a perfect T positioning as one stent strategy into the LAD. This is an illustration from a publication here. See how that ostial stent is hanging over the left circumflex ostium, not fully covering it, although occasionally you may extend a millimeter into the left main. Keep in mind that the upper arm away from the carina is always the more difficult to cover. The lower arm, the one at the carina, is the one where the stent may extend too much into the left main as you try to cover the upper arm. So when you're positioning your stent in nail the ostium technique, collimate and zoom and focus on those two ideas while positioning the stent. Try to cover the upper arm without allowing the lower arm at the carina level to extend too much proximally. This nail the ostium strategy has risk. One is geographic miss, meaning not covering the LAD ostium, particularly as the stent that you're positioning moves with the cardiac cycles and it moves with respiratory cycles. And number two, you may have too much overhang of that stent in the left main, particularly if the stent moves while you're deploying it. You may have too much overhang in the left main with malapose struts, but not enough overhang to do a proper pot. You know, you need 6 to 8 millimeter of overhang in the left main to do a proper balloon proximal optimization with a larger balloon. If you end up with something like this, it would have been better in that case to stent crossover fully into the left main, plan it well ahead, and cover the left main at least 6 to 8 millimeters with a proper balloon pot. Now, when this happens, overhang the left main that is not long enough and not short enough to be appropriate, when the stent is floating in the left main and grossly malapposed, there is a concern about the risk of thrombosis and also future access to the LAD and left circumflex. So you have to fix it. You cannot leave it overhanging like this. You may either decide to do a suboptimal pot where you pick a larger balloon and position it across the carina and make that overhanging portion of the stent opposed over the left main walls. There is a risk with that because you will be oversizing a balloon across the carina and you may create carina shift and narrowing of the circumflex. But that's one simple way of dealing with that problem. Another way of dealing with it is to add another stent that barely overlaps with this stent and do a proper pot with 6 to 8 millimeters into the left main. The problem is that you risk having too much stent layers covering the circumflex ostium and difficult access to that circumflex. Always remember, there is a risk of missing the fact that distal left main also has disease and needs to be stented. That's why it's paramount to do IVUS in most of those cases. If you have moderate distal left main disease angiographically, or you have a small diffusely diseased left main, check left main by IVUS and stent into the left main if the left main is significant. Even if the left main is not significant, is not less than 6 millimeters square, but there is moderate diffuse disease through the left main, there is a risk of longitudinal plaque shift at the edge of the left main when you position a stent close to it. So there is a risk of worsening of that left main disease when you try to nail the ostium of the LAD or barely land in the left main with your stent. So in that case, it's better to just stent up front into the left main when it's significant, less than 6 millimeters square, or even when it's not significant, but it's moderate with a heavy plaque burden. Now I will describe the second technique, which is the crossover stenting into the left main. And note that I'm using for illustration isolated ostial LAD disease, but the same techniques apply for ostial left circumflex disease. So crossover stenting into the left main, which is practically the same as a stepwise provisional bifurcation left main strategy, is used when the LAD left circumflex angle is narrow, less than 70 to 90 degrees, or as I mentioned here, you have moderate left main disease. In this case, you stent all the way in the left main and stent at least 6 to 8 millimeters into the left main, then pot with 6 to 8 millimeter larger balloon that left main to properly oppose and expand the stent into the left main. For example, if you have a 3 millimeter LAD ostial stent, do pot with 4 to 4.5 millimeter into the left main using IVUS for guidance. And when your LAD left circumflex angle is narrow, less than 70 to 90 degrees, and you try to nail the ostium, you may risk either missing the ostium, or if you try to really cover it, then you may risk having too much stent overhang into the left main, especially at the lower arm at the carina. As you're trying to cover that upper arm, which is hard to cover, you end up with too much stent at the lower arm at the carina level into the left main. And then you will have to troubleshoot it like I explained here. But better to prevent it and do stent crossover strategy in that case. And these are the provisional steps of the stent crossover strategy, which is a stepwise provisional bifurcation strategy. So you put your stent from the left main to the LAD and you do pot in the left main. If the left circumflex becomes narrow more than 75% after the left main LAD stent, then you rewire the circ and balloon it. If there is persistent circumflex narrowing more than 75 to 90% despite ballooning, or there is significant dissection in the circumflex or impaired flow, then you can do either provisional tap, which is what I prefer, or provisional culotte. With a provisional tap, you just advance the stent while you have a balloon station in the left main LAD. You deploy that stent, then you deploy both balloons simultaneously. Basically, the provisional tap is very close to provisional ballooning in terms of steps, and it's relatively easier than culotte. TAP has similar initial steps to culotte, but finishes sooner and faster with less metal overlap. And as I explained in my left main talks, TAP can be done for any angle. It does not have to be a wide 70 to 90 degree angle. Now, with either nailing the ostium strategy or the stent crossover strategy, one of the risks is carina shift or plaque shift into the left circumflex, creating narrowing of the left circumflex. This is particularly true when the LAD left circumflex angle is narrow or the very ostium of the left circumflex is bent toward the LAD. When the very origin of the circumflex is straight and the circumflex is not diseased, the risk of circumflex compromise is very low, less than 5%. When the circumflex origin is bent and spiky toward the LAD, then there is a risk of circumflex compromise when you stent because you push that spike toward the ostium of the left circumflex. Nonetheless, the risk remains low if the circumflex itself is truly not diseased, and it remains in the 5% or less range. This risk of left circumflex compromise exists with both stent crossover strategy and nailing the ostium, and likely it's a similar risk. People think if you nail the ostium rather than doing stent crossover, you have less risk of plaque or carina shift into the circumflex, but that's likely not true. It's the same risk of circumflex compromise, and it depends on how much the circumflex is diseased at baseline and on that angle of LAD left circumflex, particularly the very origin if it is spiky, with both techniques. Now, when you get left circumflex compromise, as I explained here, you do the stepwise provisional strategy. You post-dilate that circumflex and do kissing balloon, and if persistent circumflex stenosis more than 75 to 90%, you stent that circumflex. And here is a difference between the two technique, the crossover versus the nailing the ostium technique. If stenting is needed for a compromised left circumflex, it is easier to stent the circumflex after stent crossover here than after nail the ostium. If the circumflex is compromised after stent crossover, you rewire, balloon, then if needed, you stent and you do tap, preferably, or culotte or reverse crush into the circumflex. If the circumflex is compromised after nail the ostium strategy, you can balloon easily using the same wire that's already in the circumflex and do kissing balloon. But if a stent is needed, you cannot just position a stent, nail the ostium of the circumflex, because you'll end up with what we call the simultaneous kissing stent or the V stent, which is suboptimal long term. So in that case, you'll end up having to crush the LAD stent with a balloon stationed between the left main and the left circumflex, then place a left main, left circumflex stent and do SK or DK mini crush technique with the main stent from left main, left circumflex and the LAD stent being crushed. So now you are seeing the hazard of nail the ostium technique. If it works, it's great. But if it doesn't work, you may have issues with the floating stent in the left main that you will have to deal with, as I explained. Or if you get left circumflex compromise that requires stenting, then it will be a problem because you'll have to crush the LAD stent. If it requires only balloon and the balloon works, it's fine. But if it requires stenting, then it's a hassle. You have to crush the LAD stent and do left main to left circumflex main stent with SK or DK crush strategy. For all those reasons, crossover strategy is preferred by many operators for all cases, including the Euro-PCR group. Same two strategies apply to isolated ostial left circumflex stenosis. When the LAD left circumflex angle is wide, is 70 to 90 degree, consider nail the ostium technique. When you have a narrow LAD left circumflex angle less than 70 degree, or you have a bent ostial LAD into the circumflex, or when the left main has moderate disease, do crossover stenting left main, left circumflex. No need to touch the LED at all in most cases, unless it becomes more than 75% stenotic after left circumflex stenting, the same as with stepwise provisional strategy. If it becomes more than 75% stenotic, and possibly here I would use a lower threshold because it's the all-important LED, I would use a 50% threshold. So it becomes more than 50% stenotic after stenting left main, left circumflex, you can rewire and just balloon the LED. If you have persistent more than 50 to 75% stenosis despite balloon, I would stent it using preferably the inverted tap technique. And here are the provisional steps. You put left main, left circumflex crossover stent, you do proper pot. If you have compromise of the LED after pot and despite pot, you rewire, do balloon, and I'm talking compromise using here a cutoff of 50 to 75%, probably 50% for the important LED. And if you have persistent LED stenosis more than 50 to 75% despite ballooning, then you stent preferably with the inverted tap or possibly the culotte technique. This is an illustration of a narrow LED left circumflex angle that requires a stent from the left main to the left circumflex with pot of the left main. If you get significant pinching of the LED after stenting despite pot, then you rewire and balloon into the LED and do kissing balloon. But you don't need to touch the LED at all if it is not compromised with stenosis less than 50% after left main to left circumflex stent. In non-true bifurcation, including in isolated ostial LED or ostial left circumflex disease, try not to even touch at all the other vessel. Wire it, but do not do pre or post dilatation. With crossover strategy into the left main, there is no evidence that leaving a grid of metal across the other branch vessel, whether LED or left circumflex, is harmful. This likely even applies to when the left circumflex is severely diseased and LED not diseased, and where you stent from left main to left circumflex, although you do have a lower threshold to touch the LED and balloon it and stent it, maybe for a 50% cutoff. But less than that, you don't need to touch it at all. You don't need to balloon that grid of metal and open access to the LED if it doesn't develop stenosis. There is indirect evidence that even dilating the uninvolved branch in those cases is not beneficial and may worsen main branch outcomes and main branch stent outcomes. You have data from at least 4 analyses. That's why reserve LED dilatation after circumflex stenting for stenosis more than 50% or so. There is an advantage of opening the struts into the LED, but there is a disadvantage of creating LED injury with your balloon, and even more so deforming that main branch stent when you're doing the final kissing balloon. Another idea is in isolated ostial left circumflex stenosis, strongly consider IVUS for left main, but also IVUS of LAD before PCI to ensure the ostium is not diseased more than 70% diameter stenosis. If the LAD is diseased with 70% diameter stenosis, then you will choose an upfront two-stent strategy, most likely, as this will most likely be a complex true bifurcation. Also, specifically for isolated ostial left circumflex stenosis, to avoid having to stent the left main and possibly having to touch the LAD, strongly consider medical therapy before PCI of left circumflex, especially when it's not critical. Remember the importance of pre-IVUS assessment, especially to assess the distal left main when it appears to have moderate disease. And also it's important to do post-IVUS. Example, when you stent the ostial LAD using the nail the ostium strategy, ensure that this LAD stent is fully covering the ostium and see how much stent struts are extending over the left circumflex using longitudinal IVUS or OCT imaging, as you may see here, 2 to 3 millimeters over the left circumflex ostium, ideally without touching the left main, or maximum a millimeter or so into the left main. Also, keep a low threshold for rotablation or lithotripsy for calcified ostia, LAD, or circumflex, or at least perform IVUS pre-assessment, as ostia are more difficult to expand and have higher restenosis than other coronary segments. One brief note here about the so-called Szabo technique, which has been described for nailing the ostium. I discourage the use of Szabo technique. Basically, what it consists of, let's say we want to stent the ostium of the LAD. You double wire LAD and left circumflex. You load your stent onto the LAD wire, and outside the body, after you load your stent onto the LAD wire, you partially inflate it to 2 to 4 atmosphere outside the body, and you load the back end of the left circumflex wire onto the distalmost strut of the stent outside the body. Then you advance that stent basically over the LAD wire while it's also hooked. The back end strut of it is hooked onto that circumflex wire. And when you get into the body, that back end strut hooked on the circ wire will prevent the stent from going too deeply into the LAD. So basically, the Szabo technique is meant to prevent geographic miss. However, it doesn't prevent that stent from ending up too proximally in the left main. Furthermore, you're deforming the stent by inflating it outside the body, and you're increasing the chance of stent dislodgement. And this is a study that has shown that with the Szabo technique, you get significant stent protrusion proximally, and you get significant and high frequency stent deformation. So I strongly suggest avoiding that technique. I want to go over some data. There isn't a lot of data about ostial LAD or ostial left circumflex stenting, but here are some. This is a series that showed good result of the nail the ostium or floating stent strategy in ostial LAD stenting. In this 71 patient series, the left circumflex ostium was covered 2 to 3 millimeters on average. They had 10% carina shift and narrowing of the left circumflex, requiring further treatment of the left circumflex in 5% of the patient. And the left circumflex compromise was predicted when the left circumflex very origin had a bend or spike toward the LAD, whether on the angiogram or more obviously seen on IVUS. You can see here on IVUS, this is the LAD, and this is a circumflex. See how on that carina, the origin is bent toward the LAD. This is another patient. This is the LAD. Here, LAD, this is a circumflex. See how there is no spike of that carina into the LAD. Less risk of plaque shift here versus there. In both cases, the angle was wide and favorable for nailing the ostium. But here, you did have compromise of the circumflex because of that spike, whereas here you did not have compromise of the circumflex after stenting the LAD. Those are illustrations from that paper. Here they nailed the ostium, very good result. Here again, they nailed the ostium, very good result between this and that. They nailed the ostium here, very good result. Here the angle was narrow. I would have favored landing the stent in the left main because you risk having too much overhang of a malapose stent in the left main in this case. This is another study. It's ostial LAD MI. They compared a crossover or ostial nailing. It's a retrospective analysis, and both strategy led to similar short and long-term results. This is another retrospective series, and in this series, the nail the ostium strategy was much less favorable than stent crossover into the left main. Partly because on IVUS, most of those patients had significant left main disease. With nailing the ostium technique, which is this here, you had much higher MACE and TVR compared to the crossover technique. So at least this study establishes that we should not fear stenting into the left main when we have ostial LAD disease. It's at least as safe as trying to be extremely accurate and nailing the ostium. And actually, it may have better long-term outcomes to stent into that left main. And this is a systematic review of crossover strategy versus nailing the ostium. There are only 4 retrospective studies that compare the two techniques, and nailing the ostium tended to do worse than crossover stenting into the left main, which explains again why a lot of operators prefer crossover stenting into the left main. I will show you some cases I've done. This is a case of very ostial LAD. The LAD left circumflex here angle is too shallow, and the LAD has a spike at its very origin toward the circumflex. This is not favorable for nailing the ostium. So after IVUS assessment and measurements, I did stent into the left main. You see here the stent into the left main. Then I did pot. This is a 8mm balloon, pot into the left main, and after pot you can see the taper of that stent. This is a stent in the left main, and it tapers down into the LAD. The arrow points to the transition point between left main and LAD. And this is the result, great result, no significant compromise of the circumflex. This is another case here where you have significant ostial calcified LAD stenosis, and there is also proximal LAD disease. The circumflex does not appear compromised. Here we prepped that ostium of the LAD with high pressure balloon, as well as lithotripsy and cutting balloon. Then we used ostial nailing strategy. And this is the result. You can see the ostial stent. You can see that ostial stent, it's hanging over the circumflex, covering it almost fully, but not overextending to the left main. And the reason we chose nailing the ostium here is that the angle is 90 degrees. It's favorable for that, and the left main appeared uninvolved. It's most important to do IVUS here and make sure the left main is truly uninvolved before you choose nailing the ostium. This is another case here. You have ostial left circumflex, heavily calcified stenosis. We did rotablation of that circumflex. And here the angle is not favorable for nailing the ostium. It's probably best to choose a crossover stent strategy, but I chose the nailing the ostium technique here. As you may see, I position the stent, which is just on the inner edge of the dot, and I position the stent without extending into the left main. You have a couple of struts covering the ostium of the LAD, but we're not extending into the left main. We have perfect positioning for nail the ostium in this case, but it was likely better to do crossover technique, as the angle here was narrow and there was a risk of extending the stent too much into the left main than having to troubleshoot and bail ourselves out.